Start. Okay. Good afternoon, everyone. I'm Dr. Nandyala Vishwanath, consultant neonatologist and pediatrician at KIMS Cuddles, Kondapur branch. So today the topic is Amplitude EEG in neonates. So even though conventional EEG is gold standard in neonates, but due to its complex application and limited resources for interpretation, the widespread use of EEG, conventional EEG, is limited. So an alternative to conventional EEG would be this amplitude EEG. So let's see how this amplitude EEG can be applied in neonates. So the topic I'll be discussing, the objectives would be the working principles of amplitude EEG and the bedside applications, and maybe a few slides on the evidence which support the use of amplitude EEG in neonates. So first, let's see where amplitude EEG can be used in neonates. It is used to monitor the cerebral function, basically neonates who has encephalopathy due to any etiology, be it hypoxic ischemia, be it hypoglycemia, or any other cause. And neonates who are undergoing therapeutic hypothermia, we need to monitor the cerebral activity and detection of few parameters like the sleep-wake cycle and the seizures. So it is used in monitoring for therapeutic hypothermia and the detection of seizures. And there are many evidences now where amplitude EEG can be used to predict the neurodevelopmental outcome in encephalopathic neonates, especially who has moderate to severe HIE. So coming to the introduction, amplitude EEG is basically a non-invasive monitoring. It is a continuous bedside monitor where we can see the cerebral function. But unlike conventional EEG, this is a limited channel tracing. We will see what is limited channel tracing. And the instrument or the device which records this amplitude EEG is called a cerebral function monitor. So let's see how these signals are picked up. For that purpose, we have something called as electrodes. There are three types which are predominantly used. One is hydrogel electrodes, you can see on the left side, which are most commonly used and are safe in using both term and preterm neonates. And then we have a disc or cup, which are disposable electrodes. And then we have needle electrodes, which are a little bit invasive, which are inserted into the scalp to pick up the electrical activity. So these are the three electrodes which detect the cerebral activity. So coming to the recording technique, amplitude EEG can be recorded by either one channel or two channel. Two channels is the most commonly used recording technique. So if you see the schematic diagram where this nasion and then the occipital, and then the left and right external auditory meatus. So unlike a 1020 system for conventional EEG or the adult EEG, we have only limited channels to which pick up the electrical activity. So the left hand side is the odd number like 1, 3, and the right side is even number denoted by even number 2, 4, and F being the frontal, C being the central, P is parietal, O is occipital, and T is temporal. The most commonly used site is C3, P3, and C4, P4, because this is the area which is most vulnerable during the hypoxic or any ischemic event, and which is closer to the scalp, and it helps in early pickup. The electrical activity can be picked up early. And then we have something called as Z. Z electrode is the ground channel, which eliminates the artifacts and is for the patient safety. So most commonly used area is C3, P3, and C4, P4. So this is the we have a neonate where left hand side you can see the central part of the forehead. We have placed the ground electrode, which eliminates the artifacts. And the right side, you can see the C3, P3 placement. This is on the left side, and the right side, it will be uh, just above and in front and behind the ear. So central and parietal area. Let's understand how this amplitude integration works, the methodology. The signals from the channels which we have placed on the scalp, they pick up, and then it passes through something called as band pass filter. So the purpose of this filter is it enhances the frequencies between 2 and 15 hertz. And the frequencies which are less than 2 hertz and more than 15 hertz are attenuated. And it helps in elimination of artifacts. And after that, the amplitudes which are less than 10 microvolts are displayed on a linear scale. We'll be seeing the display of a cerebral function monitor. The amplitudes which are more than 10 microvolts are represented on the logarithmic scale. So hence, amplitude EEG is a semi-logarithmic display. The lower border of that trace constitutes to the lowest detected amplitude, and the upper border constitutes the highest amplitude. And it is a time compressed scale. We will see that when we see the display in the subsequent slides, the 6 centimeter corresponds to 1 hour of the time scale. So this is how the methodology of an amplitude integration works. So this is how an display of amplitude EEG cerebral function monitor looks like. So on the top, you can see there are some patient details. And then top two boxes is the microvolts which is detected. And the lowermost is the linear scale where you can see the raw EEGs of both right and left. So the topmost is the semi-logarithmic scale. If you see, the trace is 2 lines. You can see 2 lines, and in between you have 6 small boxes. So this 6 small boxes constitutes 1 hour, and the tracing you can see it represents the microvolts, and corresponding to the left and the right side of the cortex. So it is displayed on a semi-logarithmic scale. The below 2 boxes are the linear scales where you can just see the continuous electrical activity if because the amplitude is more than 10 microvolts, you can see it on a linear scale. And in between, if you see a small knob where you can just drag it behind and front and then see the tracings of previous few hours or few days. So basically, this is how an amplitude EEG display looks like. Coming to the exact trace, so if you see the trace of electrical activity, which is represented as microvolts, the lowermost margin represents the lowest microvolt, that is the amplitude, and the upper margin corresponds to the highest detected voltage. And this is called as a bandwidth. So this is called bandwidth or the trace, and the upper margin constitutes to the highest electrical activity detected in microvolt, and the lower margin corresponds to the lowest detected electrical activity. So once we have a trace, we have many classification systems for the interpretations. There are qualitative and quantitative, but for ease of understanding, most widely used approach is this Hellstrom-Westers, which is a qualitative scale. and it does not transform into any score, and it can be used in both term and preterm neonates. There are few other scales as well, but they are a bit more complex to comprehend and little bit time taking. So most commonly used is Hellstrom Vestas, and there is now significant evidence that it has a very good sensitivity um, uh, uh, to to monitor the cerebral activity. So the qualitative interpretation of amplitude EEG, three parameters are to be looked into. The first one is the background pattern, then the presence or absence of sleep-wake cycle, and the presence of seizure activity. We'll discuss in detail about all the three parameters so that we can have an understanding of the amplitude integration. So the background pattern, it is a voltage-based classification. So the background pattern can be normal, moderately abnormal, or it can be suppressed. So if the lower margin is more than 5 and the upper margin is more than 10 and not more than 25, it is considered as normal. It's an abnormal if the lower margin is less than 5 microvolts and the upper margin is more than 10. Suppressed background pattern is when both lower margin is less than 5 and the upper margin is less than 10. So this is the voltage based background pattern classification. Now, this pattern this pattern is based on Hellstrom and Vestas, has been categorized as continuous normal voltage, discontinuous normal voltage, continuous low voltage, burst suppression, and the flat trace. The difference between continuous and discontinuous voltage is based on the lower margin. If the lower margin is more than 5 and upper margin is between 10 to 25, it is continuous. And if lower margin is less than 5 and the upper margin is more than 10, it is discontinuous normal voltage. Continuous normal voltage is a normal pattern in term neonates and certain preterms, whereas discontinuous normal voltage is a bit slightly abnormal. It is seen in mild encephalopathy and certain late preterms or moderate preterms. Next is the continuous low voltage, in which the lower margin is around 0 microvolts and the upper margin is less than 5. So this definitely indicates an abnormality. The background is suppressed. And then the fourth one is the burst suppression. In burst suppression, lower margin is between 0 to 1 and the upper margin is more than 25. So it can be burst plus or minus based on the density of bursts. That if the bursts are more than 100 bursts within 1 hour, that is 6 small boxes, then it is burst plus. And if the bursts are less than 100 within an hour, it is burst minus. Flat trace or isoelectric pattern, in which lower margin is 0 and the upper margin is usually around 2 to 5. So this is seen in isoelectric activity, and there is complete cerebral inactivity. So this is the most commonly used pattern-based classification by the Hellstrom and Vestas. Now coming to the second parameter, which is the sleep-wake cycle. The sleep-wake cycle, it refers to the cyclic fluctuations in the amplitude, both upper and the lower uh, margin. And because a neonate transitions from awake to quiet sleep and then active sleep, this cyclical variation is seen. It is seen usually as a sinusoidal pattern in the lower margin of the trace. So the wider bandwidth, it resembles the discontinuous activity during the quiet sleep, and the narrow bandwidth, it is seen during awake or the active sleep. In quiet sleep, you can see grossly, you can see it is as a sinusoidal wave pattern, where there are broader bandwidth and then there are narrow bandwidth. So in quiet sleep, there is broader bandwidth, and in active sleep, you can see the lower margin is increasing and the bandwidth is decreasing. So this is a normal sleep-wake cycle seen in a term neonate. So we can categorize sleep-wake cycle as absent, immature, or developed. Absent sleep-wake cycle is when there is no cyclical variation in amplitude EEG. and it is usually seen in severe encephalopathy or in extreme preterm neonates. Immature sleep-wake cycle, when we see some cyclical variation in the lower amplitude, and it is not fully developed when compared to the um, amplitude EEG of the normal gestational age. Immature is seen in moderate and very preterm neonates, and during mild encephalopathy as well, we can see immature sleep-wake cycle. Sleep-wake cycle is developed when there is clearly identifiable sinusoidal variations between discontinuous and more continuous background activity. So, which is in a healthy term neonate, a complete, well-developed sleep-wake cycle with good sinusoidal variations can be seen. So, this is the second parameter of interpretation of amplitude EEG. And the third is the presence or the absence of seizure activity. So how seizure activity can be seen as an abrupt rise in the minimum and the maximum amplitude both. And it is usually followed by a short period of decreased amplitude. But while interpreting the seizure activity, the raw EEG should always be taken into consideration while interpreting any seizure activity. So let's see how exactly this looks like. So to call it as continuous normal voltage, you see the lower margin is around 5 microvolts and the upper margin is between 10 to 15. So this is a continuous normal voltage. But there is no sinusoidal pattern. So there is absence of sleep-wake cycle. So we can label this as continuous normal voltage without sleep-wake cycle, and there are no seizure activity. The next one is here you see the lower margin is between 5 and 10 and the upper margin is around 25, and there is a sleep-wake cycle, there is a sinusoidal pattern. So this is a continuous normal voltage and with the presence of sleep-wake cycle. So this is a normally seen in term neonates. So if you see this trace, the lower margin is at 5 microvolts and the upper margin is almost between 25 to 50 and also going up to 100. So this is a discontinuous normal voltage and there is no sinusoidal pattern. So there is absent sleep-wake cycle and not very evident seizure activity. Here in this trace, if you see, lower margin is around 0 and the upper margin is just below 5 microvolts. So this is a low voltage activity. Obviously, there is no sleep-wake cycle and there are no seizure activities. Coming to this trace, if you see on the top, the lower margin is at almost 0. Upper margin is going up to 100 microvolts and there is sudden spike followed by a dip in both upper and lower margins. So this is a burst suppression. And the upper trace shows almost more than 100 bursts in 1 hour. So it is burst plus. And in the lower trace, if you see, the bursts are less than 100 in 1 hour. So it can be labeled as burst suppression minus. So coming to the flat trace, if you see both, I mean, clearly we cannot differentiate in the right side amplitude EEG. If you see the lower trace and the upper trace are almost between 0 to 2 microvolts. So this is a flat trace isoelectric and usually seen in neonates with severe HIE. So if you see amplitude EEG in HI, there are few parameters which are associated with good outcome and there are few parameters which are associated with poor outcome. Like early normal or very slightly abnormal or discontinuous voltage activity is usually associated with a very good outcome. But if there is burst suppression, low voltage and presence of flat trace throughout then it has a poor long-term neurodevelopmental outcome. Also, for the initial 6 hours, if the amplitude EEG is absolutely normal, then it has a good negative predictive value for poor neurodevelopmental outcome. And also, if the sleep-wake cycle, which appears before 36 hours in asphyxiated neonates, is seen to be associated with better neurodevelopmental outcome. So now the question is, if can we use amplitude EEG alone instead of the encephalopathy monitoring scores like NICHD or the other scoring systems? So the evidence is there are few trials like CoolCap trial and the TOBY trial in which they had used amplitude EEG as a parameter, but they have seen that amplitude EEG, when like in CoolCap trial, when selective head cooling was found to decrease the risk of death or severe neurodevelopmental disability at 18 months. In these subset group, infants with moderate encephalopathy on EEG, which was by a discontinuous pattern, they benefited from hypothermia. Whereas those with severe encephalopathy, that is presence of burst suppression or continuous low voltage or flat trace, amplitude EEG did not show any significant benefit. The similar finding was seen in TOBY trial. So the conclusion is amplitude EEG still cannot be used as a single parameter to include the neonates in for requiring the therapeutic hypothermia, but in conjunction with the clinical parameters and the other scores can be considered for ideal candidates to start therapeutic hypothermia. So here if you see the predictors of neurodevelopmental outcome in neonates with HIE who has received hypothermia, it was a meta-analysis which was done in 2019. So here the predictors were amplitude EEG, conventional EEG, MRI, and NIRS as well. And the outcomes were seen at 18 months, which were the cerebral palsy or the other formal scoring of Bailey's to see for the adverse neurodevelopmental outcome. So they saw neonates who receiving hypothermia. Amplitude EEG was observed at 6 hours, 24 hours, 36 hours, 48 hours, 72 hours, and then 96 hours as well. So for the initial 6 hours, the diagnostic odds ratio was slightly less for detecting poor neurodevelopmental outcome. But after 6 hours, especially between 24 and 36 hours, the diagnostic odds were really good to predict the poor neurodevelopmental outcome compared to 72 hours and 48 hours. And also the presence of, if you see the sleep-wake cycle also, presence of sleep-wake cycle at 96 hours on amplitude EEG had a very good diagnostic ability to predict neurodevelopmental outcome. So what they concluded was amplitude EEG had the highest diagnostic odds at 36 hours, and the prognostic utility of amplitude EEG at 24 and 72 hours was almost similar to the conventional EEG at 24 hours. So these were the findings. So it has a very good sensitivity in predicting the neurodevelopmental outcome at a later age who receive therapeutic hypothermia. So there are broadly, if you see amplitude EEG, there are few things which have unfavorable outcome and few parameters which have favorable outcome, like abnormal or interrupted low voltage or background pattern, prolonged and marked amplitude disturbances, absence of sleep-wake cycle after 24 hours, 36 hours, 72 hours. If there is no sleep-wake cycle, it has a very poor prognosis. And the status epilepticus also has an unfavorable outcome. But if the background activity is normalized and the beginning of presence of sleep-wake cycle within 36 hours after birth, and the return of sleep-wake cycle to normal during cooling within 24 hours is considered a favorable outcome in neonates with HIV receiving therapeutic hypothermia. So there are certain pitfalls and caveats like tracing is a limited channel tracing. It covers only the small surface of cortex, and it is a time compressed scale. So the if any short lasting changes like seizure or any changes, it is very difficult to see. And interpretation of raw EEG curves requires some knowledge about the conventional EEG. And there are many internal and external factors like the electrodes which we are using to pick up the electrical activity, if there is any hemorrhage, if there is any scalp edema. These are all the factors which can lead to uh, impact the uh, understanding of amplitude EEG. So, take home points is that it is very easy, convenient, and a non-invasive parameter which can be used in the bedside to monitor the cerebral function, especially in neonates with encephalopathy due to any etiology. And it helps in detection of seizure management, but of late the Cochrane has also compared the amplitude EEG with conventional EEG for seizure detection, and it has very moderate sensitivity and low specificity. And when it comes to the predicting the neurodevelopmental outcome, amplitude EEG has, in conjunction with the clinical parameters, has a very good role to predict the neurodevelopmental outcome. So, once again, because of conventional EEG is the gold standard, but because of limited technical expertise and the interpretation, we need an alternative for which the a decent role. So with this, I finish my presentation. Thank you.